we talked about a lot of different causes of hypercortisolism in our last video, but to quickly recap, hypercortisolism can be due to adrenal masses, that is primary hypercortisolism, exogenous corticosteroid use, an ACTH producing tumor in the anterior pituitary, or an ACTH producing tumor somewhere else in the body, that is ectopic ACTH secretion. Now, how do you differentiate between all these different causes of hypercortisolism? Well, primary hypercortisolism and exogenous corticosteroids are both going to present with decreased ACTH. That's because negative feedback in this pathway is still intact. You're also going to see no response on the low dose or the high dose dexamethasone suppression test. That should make sense to you because the problem here is either that we have an adrenal cortex that is not listening to the feedback from this pathway, and that's why it's secreting too much cortisol. It's not going to listen to high dose dexamethasone. There's already a ton of cortisol and it's not shut down. Or you're getting exogenous cortisol from outside the body, which of course are not regulated by this pathway at all. That's also what's occurring with our CRH stimulation test. Of course, if you give CRH, it should stimulate the rest of this pathway to produce more ACTH and more cortisol. However, we're already producing the max amount of cortisol here, and this cortisol is exerting negative feedback on the prior parts of this pathway. So we're not going to see any increase in ACTH or cortisol if we have either of these pathologies. Because the serum chemistries and the diagnostic tests for these two are incredibly similar, I would recommend looking at the patient history and the imaging to differentiate between these two. For exogenous corticosteroid use, this patient should have a prescription for exogenous corticosteroids or an underlying pathology like lupus, rheumatoid arthritis, Crohn's, something autoimmune that would require them to take exogenous corticosteroids. And that can help you differentiate from primary hypercortisolism, where they may not have a prescription for exogenous corticosteroids. You have no idea where these steroids are coming from, but if you get some imaging, a CT with contrast would be ideal, you should see an adrenal mass. Next, Cushing's disease, you can differentiate because it will have elevated ACTH. There will be no response on low-dose dexamethasone suppression test, but then perhaps most importantly, the high-dose dexamethasone suppression test, you will see decreased cortisol as well as decreased ACTH because you have finally got to a dose of corticosteroids. They're going to be enough to shut down this anterior pituitary. We're having strong enough negative feedback here that we are going to decrease our ACTH secretion and our cortisol as a result. CRH stimulation is also intact here. Increased ACTH and increased cortisol will be the result of the CRH stimulation. That is because these cells are in the anterior pituitary and they're still listening to the feedback of this pathway. And then finally, a pituitary MRI may show a mass in the pituitary, and that would be highly suspicious for Cushing's disease as a cause of your patient's hypercortisolism. And then lastly, you can differentiate Cushing's disease from ectopic ACTH secretion because even though they both have elevated ACTH, you're not going to see a response on any of these tests. You won't see a mass in the pituitary, but if you did a CT of the chest, abdomen, and pelvis, you may find a mass suspicious for malignancy and paraneoplastic syndrome, ACTH secretion in this case. So how did they ask you about this on a board style question? Well, something they might ask you is, a 47-year-old woman presents for evaluation of weight gain, increased facial hair, and amenorrhea for the past 3 months. The patient has a history of lupus and has had frequent flares over the past year. Laboratory tests reveal a glucose of 125, decreased ACTH, and increased late-night salivary cortisol, but appropriate response to the CRH stimulation test. If left untreated, this patient's condition will likely have which impact on the patient's adrenal glands. So thinking about this patient's presentation, they're presenting for evaluation of weight gain, increased facial hair, and irregular menses, amenorrhea, for the past several months. They also have this hyperglycemia. Now, without any of the rest of this picture, this can look really, really similar to PCOS, in which you would also have increased facial hair. You can have hyperglycemia as an important sequela of this disease. You could also have weight gain. So it's hard to distinguish these two unless you have the lab values, which of course they gave us here. This decreased ACTH should lower your suspicion for PCOS and make you think that this is going to be a type of hypercortisolism. Similarly, the elevated salivary cortisol should also give you that picture. Now we have to figure out which type of hypercortisolism this is. Well, because you'd see increased ACTH in Cushing's disease or ectopic ACTH secretion, it's not going to be either of these. I don't have any CT findings to know whether this patient has a suprarenal mass, but it does tell me that this patient has lupus and has had frequent flares over the past year. You know that lupus flares are frequently treated with corticosteroids such as prednisone, so it's quite possible that this patient has been on corticosteroids for the past 3 to 6 months. That is going to be highly suspicious for exogenous corticosteroids as a cause of this patient's hypercortisolism, and the question asks us, if left untreated, the patient's condition will likely have which impact on her adrenal glands. glands, because we are having exogenous corticosteroids pumped into our system, and this pathway has been off for the past 3 to 6 months, and the exogenous corticosteroids have been taking the place of the adrenal glands, this is going to cause them to atrophy. They haven't had to do their job in 3 to 6 months, so they're going to atrophy. And that is one of the very important reasons that whenever patients are going off of steroids, you need to do a steroid taper. You can't just take all their steroids away because their adrenal glands are sleeping and will not wake up that quickly. You have to taper it down so there's gradual stimulation of these adrenal glands so that eventually the adrenal glands can take over and start supplying the cortisol the body needs again before you completely take away their corticosteroid supply. Now, I hope this video was helpful, and I'll see you next time.